Welcome, everyone. I'm Nadia Smith from the University of California, San Francisco, and thank you for joining us today for this panel on community-centered approaches to vaccine communication. We have an exciting group of panelists and a moderator from across the globe who will share their stories and perspectives about how they are working to effectively communicate about COVID-19 vaccines. Despite the first approvals and rollout of the COVID-19 vaccines occurring really in late 2020, almost a year ago, wide disparities exist both within and between countries, and which have become and could continue to become more exacerbated by booster shots. Of the roughly 5.7 billion doses that have been administered, globally only 2% of those have been administered in Africa, which represents 17% of the global population. Disparities in vaccination rates exist not only between countries, but within countries, including here in the US, where gaps still persist in vaccination rates by race, ethnicity, although these gaps are beginning to narrow. It's important to acknowledge that there are disparities in supply and access which feed into these trends. However, other factors are contributing, such as low uptake where vaccines are available, and this may become of increasing importance as vaccine supply issues hopefully become stabilized. There is growing awareness about vaccine hesitancy. We are beginning to understand that it's diverse in itself, ranging from apathy through acceptance, questioning, hesitancy, refusal, and conspiracy. Like many in the past year, I ended up shifting some of my research to focus on COVID-19, especially how it's impacting women, because that's where my work is. In qualitative research with women in Uttar Pradesh, India, we found a general lack of interest and hesitancy about the vaccine because of a perception that when they weren't at risk because they didn't know anyone who had COVID-19. In research done with other collaborators at UCSF and UC Berkeley, we found that pregnant and breastfeeding women in the US had more vaccine hesitancy, as did Black and Latina women. Reasons for hesitancy also differed by race ethnicity. We found that Black women were more likely to say that they did not trust the vaccine and Black and Latina women more likely to say that they were planning to rely on others to get the vaccine first, so somewhat herd immunity. Disparities like this have been found around the world by race, ethnicity, indigenous status, etc. Factors driving this type of hesitancy range from legitimate fear and lack of knowledge about vaccines and how they work, compounded by disinformation and misinformation, amplified by social media platforms like Facebook, WhatsApp, TikTok, Instagram, etc. Research has found that social media messaging promoting anti-vaccine events are highly predictive of the belief that vaccines are unsafe. Other research has found that the prevalence of foreign disinformation predicted a drop in vaccine coverage. It's important to remember that we're not just talking about conspiracy chat rooms or foreign bots, but also influencers, such as those who promote natural remedies, or even Facebook groups or WhatsApp chats where misinformation and disinformation are spreading. In light of this and the reality that many people spend a lot of time on social media and it's very influential, it's important for us to consider and probe on if and how social media can instead be utilized to combat misinformation and help spread accurate and useful information to a wide range of people. Understanding how to effectively communicate with people around the globe, coming with different concerns and perspectives is of dire importance. Today, we have an incredible group of panelists who will share their experience working with communities in 4 different countries to help increase vaccine confidence. Knowing the amazing demands on their time, I want to extend my gratitude for their presence today. And now I would like to hand things over to our moderator, award-winning media producer, Ngosa Chungu, who will introduce our panelists. Thank you all.
Thank you very much, Nadia, for that introduction and setting the tone for this panel discussion. The main thing that we're really going to discuss today is storytelling. Not only just storytelling, but how to do that empathetically. And so I thought I'd start with a story that I like to tell that I have actually reevaluated during prep work with these amazing panelists. They have opened my mind to seeing the story from a different angle. When I was working in global public health at the Global Fund to Fight AIDS, Tuberculosis, and Malaria, we had a Ugandan healthcare worker come to talk to us in Geneva about their experiences with ARV uptake in rural areas. And they explained that, the first time that the Global Fund tried an intervention, a lot of people were dying, particularly mothers, because they seemed not to be responding to the ARVs. So they investigated and found out that the mothers didn't have enough sustenance to be able to fight the disease and any other diseases that came up to complicate things. And so then the Global Fund made the intervention to provide food to these mothers. However, they didn't see a big change in how the ARVs were affecting their T cell counts. So once again, they went in to find out what was going on, and they found that the mothers couldn't feed themselves while watching their children starve. And so what they were doing when they were receiving the food was that they were giving it to their children. So they were taking the ARVs, but they still weren't eating. And so the Ugandan healthcare worker was visibly frustrated and was talking about how it was so important to understand where community is coming from. It's not just about delivering healthcare and expecting that, yes, we've provided drugs, everything will be fine. You have to understand the people, you have to understand the culture, you have to speak to them in a language that makes sense, because these mothers were getting exasperated by the people who were administering the ARVs shouting at them because they weren't eating, but they were like, we can't have our children starve. And so it was important that if they were to continue with this intervention, that they would have to provide food for the whole family in order for the mothers to be able to effectively take their ARVs. And at the time, it didn't register to me that empathy was lacking in the way that the intervention was being implemented in the community. And it was only until I talked to these amazing guys who are in the front lines, looking at their communities, seeing what the culture is, taking the time to really understand and meet the people that they're trying to serve where they are at, that I realized, wow, that was really the lesson from that experience, and it will continue to inform my storytelling, but in a completely different way than it has in the last 12 years. So on that note, I hope that you will really pay attention to what each of these panelists have to say and think about what storytelling means in your life, how you are currently expressing your narrative and understanding the narrative of the people that you interact with on a daily basis, and how can you take what these panelists will share today and implement it in your own lives. So without further ado, here are our amazing panelists. Our first panelist will be Kraemer Diaz, who is an anthropologist and one of the co-founders of Maya Health Alliance, Wuqu Kawoq, a healthcare nonprofit in rural Guatemala. She joins us to discuss the organization's experience combating myths and fears in indigenous communities. We will then have Luis Gutierrez, who is a public specialist at the University of California, San Francisco's Pandemic Initiative for Equity and Action, and works on COVID research projects and trainings. He will share with us his recent research on vaccine acceptance in San Francisco. We will then have Vasundhara Rangaswamy, who is a family medicine physician in training and a rural health fellow, currently working at numerous sites in rural India. She will highlight her experiences helping to dispel vaccine concerns in rural communities that have been historically marginalized. And lastly, we will have Hilary Okidi-Omala, who is the current executive director of Carolina for Kibera, a nonprofit organization that works in the informal sector in Kibera, and will share his experience working with urban community members to improve vaccine uptake in this area of Nairobi, Kenya. And now I shall hand over to you, and thank you.
Thank you so much, Ngosa. It's wonderful to be here with everyone right now. Good evening, good morning, depending where you are in the world. I want to say thank you to Ngosa for bringing the word empathy. I think we can't do this work without really having deep empathy for everyone that we're working with. I want to start off with a little story. I myself came to Guatemala over 20 years ago. I was young and had a lot to learn. I started by living in rural Guatemala. I came many years ago to think about why are there so many nonprofits in this country, yet many health and education and well-being indicators often remain poor, or oftentimes they don't get any better at all. Many of you might not know that Guatemala has over 20 different languages. Spanish is the lingua franca. It is what is used by the government and in schools. However, there are many indigenous Maya languages, and oftentimes the Guatemalan government and many nonprofits do not reach out to the people in those languages. Oftentimes, women and children are those who are most marginalized because oftentimes they don't speak Spanish very well, or they might just speak a trade Spanish. And so that makes it very difficult for them to share anything, very deep about their lives, especially in healthcare, which is in what I work. 20 years ago, when I was living in Maya Cachiquel and Maya Quiche homes, I was learning lifeways and customs. I was talking with health providers, patients, moms, government officials. What I learned deeply was about the social determinants of health. I really shouldn't say I learned them, but I felt them. I had the honor and privilege to be a part of several people's, unfortunately, their families' lives when they were losing a loved one to cancer, to diabetes, to really difficult diseases that maybe in the United States, maybe if they had been born somewhere else, maybe if they had been born into a different social class, they would have survived. My friends passed away, and I didn't want that to keep occurring. I was a co-founder of Kawoq, My Health Alliance, and we've been dedicated to helping people find access to quality healthcare. We're led by indigenous healthcare workers, and we deliver comprehensive, high-quality, culturally competent healthcare. We reach over 20,000 people a year, and we're a team of over 70 strong. We're over 80% women and 84% of our indigenous Mayan. We focus primarily on chronic disease because we don't want to duplicate care. Our idea is not to take over the government services. We want to fill those gaps in care. We want to make the system work for the people that it's there for. Vaccines arrived first in Guatemala in late February and early March, mainly for healthcare workers. I'm grateful to say that our health team was one of the first 200,000 people in this country to be fully vaccinated, which is a real honor for our entire team and helped us to keep working home to home in order to provide services. I would say about late May, more vaccines started to come into Guatemala. But the window between March and May and June was a key window where we lost major time in this country. And unfortunately, that means many people have lost their lives. Unfortunately, we were trying to purchase, the government was trying to purchase through the COVAX mechanism, and unfortunately the vaccines never arrived. We were trying to purchase Sputnik and things just never seemed to go as is. What the government showed, what was in the news, it was just really hard to understand what was going on. And it created a lot of doubt. It created a lot of problems. Why aren't the vaccines coming? Why aren't they there for us? We keep hearing that they're going to come and they don't arrive. And so there was a lot of doubt kind of growing within the public. By May and June, we received donations from other partner countries for Pfizer and for Moderna, and we were able to really start vaccination in the country. Unfortunately, right now, the problem that really plagues the system here is that it's very confusing. There's different shots on different days in different health centers at different hours, and there's really long lines. So it's really complicated to actually access vaccines. If you are able to access vaccines, you often have to wait in a long line. And if you have a job, sometimes they won't let you off in order to get that vaccine. The most people who are getting vaccines in Guatemala right now today, I think we're at 17% of the country being fully vaccinated, of over 18 million people. We have a long way to go. I think we're about 27% of people have their first vaccine. It's mainly been people of middle to upper class who have been able to access the vaccine. And oftentimes what we're seeing is a lot of doubt and a lot of hesitancy and a lot of fear. A lot of people that are scared is because we can trace back to a lot of mistrust that has happened within Guatemala with the government. Unfortunately, there was a 36-year civil war here, often referred to as a genocide, when the government took over many indigenous communities and over 200,000 people were killed. And unfortunately, there's never been a healing. There's never been a recognition of that genocide. And oftentimes people here are still very concerned. What is the government telling me there's no real good information. Is COVID real? What I see on Facebook tells me this thing. What I receive in WhatsApp from my family members tells me that the vaccine will only kill me. I don't want to get the vaccine. So the doubt has been really difficult. And unfortunately, the government has not done a massive campaign to get the information out, and they're not getting the information out in over 20 different indigenous languages. So that just creates more misinterpretation. I want to share a story with you about one of our patients named Maria. She's a 56-year-old Kachikel woman. She has been our diabetic patient for many, many years. She's built a great trust network with one of our nurses. She came to the clinic and our nurse said, "You're in a high-risk category. It would really be better if you would get the vaccine. It can help save your life." And she told our nurse, "My family tells me no, that COVID isn't even worth it. It's not to worry about. And in fact, it's the vaccine that's going to kill me." Our nurse really worked with her on it about why the vaccine is important, about what COVID is. She used education materials and talked with her directly. And I'm happy to say that Maria got her vaccine. She's now fully vaccinated. So I think we can say what works: trust, empathy, understanding someone in their language, being able to really capture who they are and what their worldview is. It's meeting patients where they are. Sometimes the top-down idea, people are scared. There's a lot of misinformation, all sorts of information. And people really trust when they can get it close, one-on-one with someone that they know. We at My Health Alliance are working really hard to try to fit all sides. We're working on the trust-based relationship one-on-one and in with our patients and our families, but we're also doing a massive campaign to over millions of people every day in different Mayan languages through the radio, focusing on community radio that gets to where people are on networks that they already trust, trying to give them the information that they need. Thank you so much. I look forward to talking with you more later.
Thank you, Anne, for sharing your story in rural Guatemala. And something that you brought up in your stories is this lack of trust. And that is also something that is a through thread between all of the stories that the panelists will share. And I think it's fitting that Luis is the next person to talk, as his research has brought up some mind-blowing information about just how this mistrust can be created, and actually what might be the solution to tackle it. So over to you, Luis.
Thank you so much. And I kind of want to have you introduce me for everything I do so that I could have everybody hear that my results are mind-blowing. I'm going to try to live up to that, you all. Good morning. It's morning where I am, so good morning, everybody. As Ngosa said, I'll be talking about some research results that we gathered from data within San Francisco about vaccine uptake within San Francisco, which, if y'all don't know, San Francisco has had an incredible response and has really, the city has really done a fantastic job and is one of the leaders in terms of vaccine uptake, and still has people who are not getting vaccinated or who have some, legitimate concerns or other issues that they're thinking that's going on in their lives. So I'm going to explain some of this to you. The study goal was to really understand kind of this landscape, to understand what was behind some of this vaccine hesitancy and what was it that motivated the vaccine uptake. So our team conducted interviews with 97 folks. These were semi-structured interviews conducted in English and Spanish. We had capacity to do Mandarin, Hindi, and Tagalog, and there's not slides right now. Sorry, I'm just talking. But we conducted our interviews in English and Spanish. They were 20 to 35 minutes in length, depending on, we got approval to extend the interview time. We originally started with 20 to 25 minutes and then thought to ourselves, this is not enough time. Participants were paid $40 each for the 30-minute interviews. And we talked to 14 folks who we identify as key informants. So these were people who worked in the vaccine call center for the city and county of San Francisco. Their job was to call residents who were at higher risk for COVID or who were already within our system from the contact tracing and case investigation database. And they were offering to help people make vaccine appointments. We also talked to 83 people within San Francisco who had recently tested for COVID. And this could be tested for any reason. They were San Francisco residents who were in the COVID testing database. So we called them, and they were, everyone who we spoke with were adults ages 18 and over. And we did not do any interviews with minors, but we did talk to parents. Some of the questions, like typical questions that we asked folks, were things like, walk me through your thoughts and decisions leading up to you getting vaccinated. Who do you trust for health information? What are your thoughts about the COVID vaccine? What kind of conversations have you had with your friends and your family about the vaccine? What are your thoughts about vaccinating your child? What are your thoughts about being vaccinated and testing positive? So things like this. These are just some examples of the questions that we asked of our participants. And we used the theory of diffusion of innovation. And this is kind of like a theory that exists on a bell curve, where you would say that very few people kind of start to uptake the innovation at the beginning, and then it kind of goes up, and then it sort of peaks, and then it gradually comes down. And ideally, it looks a little bit equal. And so there's 5 categories of folks within here. So there are innovators, early adopters, early majority, late majority, and then the theory calls folks laggards at the very end. Our team was like, well, that's not a very nice word to call people, so we changed that to last adopters or decliners. And the way that we defined these categories in terms of our research was the innovators. We decided that these were folks who had their first dose before January, just because of the vaccine rollout in the United States and what this looked like. This is why we created these categories in this way. The early adopters we defined as people who were in our first tier. They were the first folks who were eligible to be vaccinated, and they got vaccinated as soon as they could. The early majority were people who were in later tiers, but who got vaccinated the moment they were eligible. And then the late majority we defined as folks who were reluctant or undecided, or who had some kind of hesitancy that delayed their vaccination. And then the last adopters and decliners, they have some hesitation, or they're just simply not interested in getting vaccinated. The way that this looked like for our 83 individuals from the San Francisco testing database who agreed to participate in our study were that we had 2 innovators and 20 early adopters, 45 folks in the early majority, 16 people in the late majority, and 7 people in the last majority and decliners. So it did form a type of bell curve within our data. And we conducted a rapid analysis, which I'm going to talk about some of the results from a rapid analysis, and we're using a method called rapid matrix analysis for this. We're also going through and doing, for my research friends, we're going through and doing a more full thematic analysis, and we're starting our coding process right now, but we are currently writing up the results from that rapid analysis. And so we had different findings according to the different categories within the diffusion of innovation. The thing that I feel like I'm most excited about, there's a couple things about this theory that I really like. It's sort of like a very sort of snooze fest kind of theory. People don't use it a lot, but it really works with this. And I love it because it predicts that not everyone is going to uptake a behavior. It is normal human behavior to not uptake a behavior change immediately. And so I think a lot of the ways that folks are thinking about and talking about unvaccinated people in countries where the vaccines are readily available to everyone. This is very different, obviously, when we have the vaccines not available to everyone. But the ways that people are thinking about and talking about the unvaccinated are can be really unhelpful in terms of helping people to make behavior change. And so we found that perceptions of the people in the later categories are very different than the perceptions of people who are in the earlier categories. So for example, the ways that the innovators, early adopters, and early majority folks talk about the unvaccinated, they say people are annoying, selfish. These are like direct quotes from our participants, that they're idiots, anti-vaxxers, that they're ignorant. We had people also say, they label those who have an emotional reaction to vaccine resistance as stupid. There was one person who said his parents don't understand the vaccine and they think it's a government conspiracy. And then he said, what's the point of, even talking to them? People don't see the point of even talking to them. So you can go ahead and write in the chat if you would like about your thoughts about how likely it is that somebody would actually, change their behavior based on this type of language. On the other hand, we had people who were unvaccinated talking about how they were scared, confused, they had mistrust, concerns, they were overwhelmed. And so it's a lot of emotions that are really behind this, even for folks who were talking about misinformation that they had, which we might label conspiracy theories, right? I might be like, oh, I think that's a conspiracy theory. What's based in that, what's founded in that is fear, legitimate concerns. Through the misinformation, folks are having concerns and an emotional reaction. And so, for example, we see like a unvaccinated person who says, I just feel like, I hear people saying that they're going to pass away from taking it. I'm really not trying to get it, but I know that if I have to, I will get it. So this person is a healthcare worker, a home care worker who will eventually have to be vaccinated. And so we hear a lot of really concern and fear behind that. And I think I'm at my time. I'll leave it at that. I'm so excited to listen to what the other panelists have to say.
Thank you, Louise. I think for me, what was very shocking about the findings was not that early adopters had this sort of faulty idea that they were better than everybody else. That is something that tracks around the world, even here in Zambia. When we started the vaccine rollout, a lot of the early adopters were using very similar language and weren't particularly empathetic to the anti-vaxxers. But what shocked me, and I don't know if it has shocked you guys, is that those who are now uptaking the vaccine, those are the people that are the best people to be the spokespeople to talk to people who are considered anti-vaxxers or those who are hesitant. That is what really shocked me. I was like, wow, so it seems that those who have taken the time to do their research, to give scope to their fears and have been treated in such a way that it has helped them to then get the vaccine. They have an understanding of what those fears are like, what it feels to be a person who isn't vaccinated, and they're using that to then reach out to the community, which is awesome. And that kind of fear is interesting and is something that is actually also reflected in rural India. And so it's befitting that Vasundhara is the next panelist to speak. Even though there is a similarity in fear and mistrust, there is a difference in how that has percolated in the community. And so Vasundhara will talk more about that. Thank you.
Thanks to UCSF for hosting this and having me here. And thanks to my previous speakers who have emphasized various aspects that I will also try to cover from my personal experiences. So I'm going to build on the same topics really, on empathy, on communication, but very Indian way of, very Indian examples. So what I have been doing during COVID, and it was totally unexpected because I am actually supposed to be training in family medicine, very seriously, not looking, with my blinkers on. But COVID came, and then I got pulled into training several organizations, several grassroots organizations in India, and a lot of them non-health organizations. Working in different parts of rural India on the disease and vaccination, and it's still ongoing. So, and the funny thing is, I keep saying that face-to-face communication is the best method of communication, but all these trainings, most of them are done through the digital world, but this is the training for trainers. And I have also been meeting people on the ground, and it doesn't work otherwise, without meeting people. And I have been traveling out of personal curiosity to different places, and I just, ask about their feeling about COVID and vaccination. The trainings have been in simple language, in non-scientific, using non-scientific terms on, but the science behind COVID, and on vaccines, on home care, or who do you call, or when do you actually refer a patient. And another very key factor in communication, or component in communication, is listening. It's not just talking, but listening, because we can talk as, you know, as the privileged or educated lot, but it can be completely disjointed if we don't listen and don't modify our training material according to what the people need or expect. Now, rural India, in my 20 years of, or a little bit over 20 years of traveling in different parts of India and being associated with different rural healthcare organizations, is isolated, disjointed. It's a different planet altogether, as if it's an island and there's a deep sea or a deep ocean separating the privileged lot, and or a deep gash. You know, you can call it anything you want. And in terms of information, it's a black hole. If it reaches there, there is hardly anyone to authenticate that information, that it is real or it is a myth. It is, you know, that's what I feel what happened in COVID and the misinformation. It's also a clinical desert where healthcare facilities are abysmal, and you know, it's not even affordable in many ways. And another important factor is people don't have good food, and that is a vaccine for me. I consider good food as vaccine. Most of rural India is still off the grid, even if there are WhatsApp messages coming in, but I would say off the grid because a large part of rural India, there's no good signal connectivity. Then one doesn't prioritize the data plans. Like if it gets over, then, you know, because they would rather spend on something else than recharge their phones. TV is also a privilege. You know, only a few may have it. Electricity is a privilege. And then we have the male member would possess the phone most often, not everyone in the family. And then because schools are lacking, even the messages that come on WhatsApp, or, you know, even if they're important messages, or even registration for the vaccine, is not understood by everyone because there's this language barrier. So I would still say that a lot of India is still off the grid, a lot of rural India especially. So I also say that they have the birds, but we have Twitter. You know, they cannot tweet. So it's like that. And in this backdrop comes COVID, along with you know, the vaccination drive. So you can imagine that when people were dying and vaccination was going on, so they connected a lot of them connected the two and two together and said, okay, because we are getting vaccinated, people are dying. And the myths or the hesitancy increased because they said that, okay, maybe the government wants to decimate our population, and that's why they have a separate vaccine for us, separate vaccine for the rich. And then we would try to say that, you know, it's the same as vaccines for children, but they said no, but maybe a vaccine for children to save them from infectious disease, they get saved. But in our case, we are dying after vaccination, right? So things like that. Now, I'll give you some personal, you know, experiences and examples and extrapolate from that. Like I walked into this community health center where I saw very stern-looking policemen with guns, quite intimidating. And they were quite loud and driving off people who were waiting there. And I said, why are you driving these people away? And they said, they are here for getting vaccinated. So I said, oh, that's good. No, there's no vaccine for them today and they have to go. Okay. So I walk into the vaccination office and say, so can you please explain this to me? And I said, we have vaccines only for the second dose, but they are here for the first dose. Secondly, we have vaccines for this particular age group. We don't have vaccines for this age group that is here. I said, did you even communicate this to the people? Because what we generally do is come and get your vaccines in this center, come and get your vaccines in this center. We don't say that we have only these number of doses or we have only, we have it only for this age group. And now you're turning away people. We took a lot of efforts in, convincing people to come to get vaccinated, and then we call the police to drive them away. So what am I expecting? What's the next step? Are they going to come back? Then there were other methods of coercion, like taking away their food coupons, and forcing them. If you do not get vaccinated, then your food coupons will be taken away. So again, it also increases the suspicion in people that why are they doing this? And one has to realize that COVID is something new. We haven't had a pandemic in 100 years, and we haven't vaccinated the adult population like this. Child vaccination is common. People are used to that, but no one is used to mass vaccination of adults. We haven't seen that, so it's not easy to convince people, especially in the villages, and certainly coercion is not the way. Then another example is where I went to this village and the whole village was not ready to take the second dose because they said, we took the first dose, everyone felt sick, and we've never been so sick in our lives. We have been going to the forest, we walked for 8 hours a day, and we've never fallen sick, but this is the first time we felt sick after this, taking the first dose of vaccine. We did not get any, any paper or receipt. We did not have a phone number to call, and no one came back to inquire about our health. So that whole village decided not to take the second dose, and in fact, they even drove away people who came to vaccinate them. So that's another thing where there is no continuity of care. That's another example where we just leave them alone after this. Then another thing we keep hearing is that at the vaccination centers, the medical officers or even the staff, they are turning away people with diseases, with comorbid conditions like diabetes or pregnant women or breastfeeding women, which is, in fact, these are the very people who need the vaccine. So it's even ignorance at this level, because when I spoke to some people who were administering the vaccine, they said, I do not want to take the responsibility if something goes wrong. If these people die, then I said, no, but there are guidelines on this that you could vaccinate all this. So even the guidelines have not reached the last person who is vaccinating folks. There are so many gaps you find, and I have seen that it is these organizations or foot soldiers or the not-for-profit organizations who are doing tremendous work silently and without being appreciated. But they are really helping many countries achieve their target for vaccinating people, because I think it's mainly because they are there with them all the time. They are with the people. They speak that language. They look like them, and they don't force them. So it's
Vasundhara, if you could please wrap up so that we can move on to the next panelists and give everybody the time that they need. Thank you.
Yeah, so I am done. Yeah, so that was my last comment, that we shouldn't forget the last mile workers, whether it's from the public sector or from the not-for-profit sector. Yeah. All right. Thank you.
Okay. So what came out with Vasundhara's experience it isn't that it was whether you were vaccinated or not. It was about community trust. So they didn't trust if, you know, a healthcare worker had been vaccinated or whether the government was trying to tell them this was the right thing to do. It was about what the community believed. And with the misinformation that was flowing, the point was to interrupt that flow and change the narrative there. And that's something that is interesting and something that Hillary can show the difference between working in the global south in the rural areas versus the urban areas, how there are some similarities, but at the same time, because there is a difference in the way community is created, that presents its own challenges. So over to you, Hillary.
Thank you very much, Ngosa. This is Hilary Omala joining from Nairobi, Kenya. Yeah, I'm Hilary Omala, working for Carolina for Kibera. I've been in this sector for about 16 years. Carolina for Kibera is an affiliate program of the University of North Carolina, but also registered in Kenya and headquartered in Nairobi. We have largely been operating in the informal settlements of Kibera, but we began our expansion to 7 new counties, and very soon we'll be known as CFK Africa, and our focus is on improving public health and economic prosperity in informal settlements. So a bit of context. Right now, our country has tested about 3 million individuals. 10% of those have been positive for COVID-19. The case fatality rate has been as low as 2% for most of the time, but we're also aware that we have some excess mortalities, deaths that have not been accounted for, especially those that happen in the rural parts of the country. Testing initially was largely as a return to work requirement, travel requirement. Now is largely voluntary, or people who present themselves in facilities with conditions that meet the COVID-19 test definitions and are offered the test. And that is slowly changing as we continue to progress. Nairobi, which is our capital city, accounts for 40% of those cases, and they are largely concentrated in informal settlements such as Kibra, where we have been working for this many years. In terms of vaccines, we now have most of the WHO approved vaccines. We have Pfizer, Moderna, AstraZeneca, J&J, Sputnik, and Sinopharm, but the uptake has been very low. There is a target of about 70% of the population, which is roughly 30 million people. We are now at 3%, and people who have taken their second doses, most of them haven't returned to take their second, and we now have a 30% that are accounted for as defaulters, which means they didn't take their vaccine, their second and final vaccine, at least 2 weeks when they were due to take one. There are so many drivers and stories around vaccine acceptance. One of them is right now, I feel like most people have appointed some guinea pig. They are waiting for them to go for the vaccine. And if nothing happens to them, then they will take their turn. At some point, for the longest period possible, healthcare workers drove the low uptakes. They were less eager to take the vaccines, and they were always at around 20% of the uptake. That has changed quite a bit to now about 64%, but these are largely community health volunteers who are leading these efforts at the community level by example. As they give information, they need to show that they have also gone for those. In the recent past, we have seen some increase in terms of the uptake from the day we adopted a community vaccination outreach program. It is a come to me approach where people would rather have you bring the vaccines to where they work, where they congregate on a daily basis, as opposed to them coming to a facility to take those vaccines. There might be a slight challenge with that in terms of loss to follow-up, and now we're driving efforts towards decentralizing vaccine distribution to community health centers where there is an element of trust that I would go to a facility, take a vaccine, and if anything happens, I could go back and ask questions. There are still many barriers. Initially, we had issues to do with access to those vaccines and priority groups, but now we have myths and misconceptions. The trending one right now is that 2 years from the day you take your second dose, you will be walking around like a stick with no flesh. And since no one has lived that period and experience, it's really difficult to demystify those. But generally, the effects of COVID-19 in most African countries has not been as devastating as we may have seen in other countries across the world. And people are asking themselves, why should we take a vaccine if this disease is not as dangerous as has been portrayed to be? In terms of communication, 60% of Kenyans right now have some access, especially in those in urban centers, to some WhatsApp, Twitter, Facebook, and you have these random messages circulating on a daily basis. There is word of mouth. Facilities have made sure that information is given whenever you present yourself to those facilities. And the hard to reach have received information, at least from community health volunteers. We have played a huge role in just making sure that there is behavior change. And this has been through constant reminders, through posters, communication, wash stations, access to services, including testing, immunization, and everything that comes with it. And we are hoping that that will continue to change how people look at things moving forward. In terms of lessons this far, I think there are many, as much as many people are beneficiaries of the essential immunization programs, so in immunizable conditions during our childhood, and those of us who are parents have taken our children through that. I think most of us have do not have the foggiest understanding of how vaccines work. And probably that's part of the reason why there are these misconceptions across the world. Number two, we need to focus on the importance of level 1 of healthcare provision, and this is the involvement of community healthcare workers. And you're basically putting health and health issues in the hands of people who are affected and having them design solutions that are lasting to those problems. I've also seen a real concern in terms of male involvement. If you look at the stratification by age and sex, looking at fatalities and mortality, you realize men have been largely affected. And I feel like we need to put men at the center of these discussions to drive the conversation around mitigation and response. And lastly, which is likely to be a bit contentious, is that I think Africans largely need to begin to understand our role in this whole issue around global health security. That as much as conditions such as this are not likely to affect us as they have in other parts of the world, with all the geographical differences, weather, climate, and all these things, we indeed have a role that we need to play. And as soon as we begin to play these roles, things are likely to turn around for the better. Thank you very much. Back to you, Ngosa.
Thank you, Hilary, for wrapping up what has been an amazing and diverse group of panelists and healthcare workers who are doing the Lord's work around the world. You guys are truly superheroes. We thank you for your service, for you taking the time to share your insights. And so now we're going to all just have a little bit of a conversation to sort of wrap up and tie up what we've discussed today. And so, you know, a through thread has really been how in each community you have needed community members to be a part of solutions with vaccine uptake, whether that is training people to be on the front lines, whether it's, you know, finding spokespeople in the community to be able to pass on information, or whether that's, you know, ensuring you're giving out information in the right language, or you're not using jargon, or, you know, as we had said from the beginning, as a healthcare worker, thinking about how you can meet who you are serving where they are at with empathy. So what do each of you have to sort of advise people who are in this work or would like to volunteer to help in their communities, or looking to implement some of the solutions that you guys have shared? What are your suggestions for how to go about recruiting people with empathy and imparting how important empathy is in the work that they will do? So I'll start with Anne.
Thank you, Ngosa. I think trust is one of the key pieces. And I think for us, working with the information we have and sharing it closely with networks is really important. And then by doing it with what works here in Guatemala, listening to the other countries, there's a lot of similarities. We have areas of the country without much signal, but I would say we have a lot more phone users here. However, the main way for news to get across here is radio. And so using community radio in the languages has been really key for us to get the word out. We're also using social media and WhatsApps, trying to get those information shared as well. But I think doing it on a trust basis within the language that the people speak, I think is really vital, and the mediums that they're used to.
Thank you, Anne. Luis, if you could give us your insights next, please.
Yeah, I think that within our research, we saw that sort of the negative perceptions of the unvaccinated people really served as a barrier. And for some people, that actually kind of made them dig in more, or it made them just give up. Like, why should I even do this? And one of our main findings that we had was that conversations in and of themselves can change minds. And these are usually conversations with trusted individuals. So whether that might be a primary care provider who somebody has a relationship with, or a friend, just being open to having some discussions, hopefully done in a non-judgmental way, really can help facilitate mind change and can help facilitate vaccine uptake amongst people who are unvaccinated.
Thank you, Luis. Vasundhara, what would you like to impart to the audience today in that regard?
Sure, thanks. One is, what has worked is reassurance and telling people that we are there for you 24/7. There is a helpline that is us. You give them that assurance that let them trust you that if something goes wrong, someone is there. Yeah, so that has worked. Even in the vaccination centers, people have taken vaccines only if the person they trust is there from morning to evening. They want to see that person. Then even involving local youth, mobilizing local youth, and then involving local leaders. So the politicians sitting far away or the Bollywood stars telling about vaccination, that hasn't worked. But if a family member takes it and nothing goes wrong with them, or if their local leader takes it and there's no side effect, and that has worked more than someone sitting far away and someone who doesn't show their face. So one is reassuring, one is being there for them, and involving local youth and local leaders, I would say, has really worked well. Yeah. Thanks a lot.
Thank you. Thank you very much. And Hilary, what are your thoughts?
I think it's been very well covered. Go back to the issue of trust and how trust is built based on our actions. If you are the appointed guinea pig, just play a role. Go take the vaccine and let others see you and trust the process. And they would also take their time.
Okay, so we have a question from Kenya, which is how has your experience been with young people who have been deemed super spreaders? I'm not sure where that has come from, whether that is a myth or whether that is actual truth. Because here in Africa, because of our youthful population, we really haven't had the kind of numbers that others have experienced around the world, but maybe that may also be because we are more asymptomatic. I'm not sure. So I'm going to start with Hilary, seeing as the question came from your country. Is this a myth or misinformation that's going around? Is there research or evidence to support this? And so, if so, is part of your strategy about dealing with young super spreaders?
Yeah, thank you. That is a case here, even though not as proven in terms of research, but we have seen a large concentration of positivity rates among young people. And the fact that most of them had that you're not likely to be as affected if you are young, say below 30 years, made them a bit more easygoing and interacting without necessarily following the protocols put in place. But what we are what we are telling these young people right now is that as much as you're not likely to be affected as the elderly, you are likely to take the virus to your parents, your grandparents, and other significant people in your life, and is likely to have a bigger impact or effects on them, including loss of life. And so that's slowly changing as we continue to communicate, but that's the case in Kenya at least. Thank you.
Thank you, Hilary. So here in Zambia, what happened was, with the first few waves, there weren't very many deaths, and if they were, it tended to be the older generation. But with the third wave, younger people were dying, and some prominent, young people, public figures, were affected, and that really changed how people thought about the virus and the vaccine, and it caused a huge rush for people to start getting vaccinated, and affected how people were getting their second dose for a little bit. So I'm wondering whether there are parallels between other parts of the world. So I'm going to go to Vasundhara. Are you seeing that in India with young people, and has that changed things? I know there was a difference between, in the rural areas, COVID hasn't really reached there as much as it did with the devastating wave that happened in the urban areas. So what has been your experience?
Yeah, thanks, Ngosa. So in the rural areas, actually in the second wave, many parts of rural India were affected, but there is undercounting of deaths, and people didn't actually get tested or reach the hospital in time. There are pockets that had minimal damage, but otherwise it has created a lot of loss of, it did cause a lot of lives lost in the rural areas. In the youth, I noticed, again, this is personal, that whenever I looked out, there were youth going on the motorbikes or on two-wheelers, 4 or 5 of them together without wearing a mask, And the news, like you said, it was always about older people dying. So they used to go out, dare it this way, even though there were lockdowns or even though there was a mask mandate. I saw a lot of youth going out without a mask and thinking that they won't be affected. And then again, coming to the truth or the science behind COVID wasn't explained to people well, right? That there are asymptomatic carriers or pre-symptomatic carriers. So when that science doesn't get into people's heads, it's quite difficult to convince people, and it's something that you cannot see, and people are not dying around you like flies. So it's very difficult to convince people that even you could, it's not just about your life, but you could be a carrier and take it back home. And the youth are more mobile because of doing the daily chores or work. So that's why I would say, but I wouldn't say that the virus was attacking the youth in the second wave. Not really like that. But there were reasons for them to be the spreaders. Yeah, thanks.
Thank you, Vasundhara. Luis, have you noticed anything in San Francisco that would show that youth are super spreaders in your region, or is that not something that has come up in your research?
We didn't have that in our data. What we do have, however, is some knowledge that it looks like youth sports and extracurricular activities, because everyone 12 and up is eligible for the vaccine. And I believe that for 12 and up, vaccines are required in San Francisco. So what we did see and what we have noticed is that what seems to be driving some of the outbreaks that we've had in the United States are some of those extracurricular activities with youth. But what we did have in our data was discussions about decisions around how to vaccinate our children, or how, for our parents, what is it that goes into this decision for vaccinating children? A lot of people just really want to keep their kids safe. And so when people are choosing to not vaccinate their children, they think that they're making the best decision to keep that child safe. And so I think that our messaging for parents needs to really be aware of that parents are just trying to keep their kids safe.
Excuse me. Thank you, Louise. So, Anne, have you noticed anything in Guatemala? Excuse me, I'm sorry.
No problem. Thank you, Ngosa. In Guatemala, it's mainly multi-generational households. So often youth live together with their grandparents and their parents. And I would say from the beginning of the pandemic till probably May or June, people tended to really stay at home, wear masks, and be a bit more protected. And it was often the person who was going out to go to work that sometimes would bring home the virus to someone at home. I would say currently the country has opened up much more and people are a lot more out and about. And so I think what's happening now is that, especially in the rural communities, if you do have COVID, you are ostracized. And so often people are not going to get tested because they don't want to be ostracized by the rest of the community, because they don't want to have it. They don't want to be someone who kind of has the big red A on their chest that they have COVID-19. And so many people are not getting tested. Unfortunately, they're in denial that they might have it, and people are passing away at home. Oftentimes family members are not telling others in the community that they've had COVID-19. And so there's a lot of underreported deaths, underreported cases. And so right now I think we're dealing with people sort of hiding it to the best of their ability, and other people saying, well, I have to go to work, I have to live because I have to eat. And so God's going to do with me what I will, because now it's been a year and a half. And so what else can I do? And so I think we're kind of coming to the phase where people are kind of just going for it. And unfortunately, that does mean an increase in cases because people are bringing it home.
Thank you, Anne. So I think what we have seen here is that there are similarities and differences across rural and urban areas, different parts of the world, the global south versus the global north. But what is true everywhere is that mistrust is a big deal and really affects how vaccine uptake happens in communities, and that it's really important, whatever interventions that you put in place, that they are empathetic. So I think a great way to wrap up would be to ask each of the panelists to tell us from what you've heard today from your colleagues around the world, what are you going to do differently in order to be more empathetic as you continue this fight against COVID? So I'm going to start with you, Louise.
For me, I mean, I'm going to take this individually because before doing this research, I was also like, oh man, these unvaccinated people, like they're really ruining it for me. They're making my life harder, right? So individually, I also had a lot of these kind of negative perceptions of people who are unvaccinated. So now I'm trying to help spread the word of our findings that it's not that people are selfish. It's not that they are these, anti-vaxxers who only believe in conspiracy theories. There might be some of those individuals, but really what's behind people's decisions to not vaccinate is fear and concern for their safety. And so trying to have empathy for that, trying to create interventions to help change people's minds that are based in, just understanding that people are afraid, that that's what's behind that decision-making process, and trying to engage them in ways that they will trust, and through routes of people who they trust already and who they can have communication with. I really think that that's where, at least in the United States, where we can make some changes and try to bring up our vaccination rate.
Glad to hear it, Louise. And Anne, what are you going to do differently or continue to do the same if you have been validated by this panel discussion today?
Well, thank you so much. I think a lot of has been validated. I think listening to what's happening in all the different countries and locations, I think continuing to work with empathy and trying to provide the best communication possible and really connect on a trust basis is so vital. I really echo Luis's information about the study and how, we can't really just isolate people and polarize them more to say, well, you're an anti-vaxxer. It's not always that case. I really do think there's a lot of things behind it, the emotions, the fear, misinformation, and we have to work harder in order to meet people where they are.
Thank you. Hillary, how are you going to move forward after this discussion?
I think it makes me very comfortable to also hear the experiences from other countries and how similar they are to the struggle that we have in Kenya and other African countries. But for me, the shift towards behavior change communication and how important that has become in terms of dispelling all the rumors around vaccine and everything associated with COVID-19. But I'm also urging everyone across the world this time around that we keep the current preventive measures in place because they will save us from many other infectious diseases moving forward. So that's likely to be important moving forward as well. And we hope to continue with that.
Thank you, Hillary, and thank you for showing the importance of how this fight is not only hyperlocal, but it is on a much larger scale. The whole world is affected, and everything that we do as individuals has a greater impact on not only our communities but the world. So last but not least, Vasundhara, what are you going to do out there in rural India?
Thank you. Yeah, so continue my work with creating more awareness in rural India. And I realized this even more during these COVID times. There were so many questions and there were so many simple answers, but it was just filling this gap between rural India and being a privileged person. So people soak up truth like a sponge, and we need to listen to them and their expectations. So I would like to simplify science and make it contextual and make it available for people. And then definitely strengthen the primary care systems and including work with the unregistered medical practitioners, which I haven't mentioned in my talk today, but they are the first point of contact. So we can't isolate that whole cadre of people also. So working with them, and then not to underestimate the power of the last mile workers. And seriously, that they have the things they can achieve. They form an important link. So I would just end by saying that it is, the same old grandma's recipe, sprinkling love in public health, and it's not rocket or Tesla science. We have to be empathetic and show let people trust us, be with them all the time. Thank you.
Thank you, Vasundhara. So I think the real takeaway here is that empathy is key, and that is done through understanding your own story, and then also giving space to the different narratives, whether you identify with them or not, or agree with them or not, that you allow the voices that have fear, that have mistrust, to have their say. And that there is a way to fill that void that the misinformation has filled if you keep steadfast in your dedication to the truth, your dedication to the work. And as we all around the world continue to work to get a hold of this pandemic, and as people see for themselves how the vaccine is helping with the fight, that we will get more uptake. So thank you very much to the University of California, San Francisco for organizing this panel. Thank you very much to Anne, Luis, Vasundhara, and to Hillary, and a special shout out to Kelly and Katie, who have been working behind the scenes to help us prep for this panel and to ensure that our narratives have been powerful and helpful to you today. And thank you very much to the technical team for recording this Zoom. And I've been Ngosa Chungu, and wherever you are in the world, have a good day. Or if like me, Hillary and Vasundhara, you're on the other side of the world, have a good evening. Thank you.
Thank you very much and bye.